So good afternoon, everyone. My name is Ananda Plate. For those of you who don't know me, I'm NP's Operations Manager in Brussels, and I will be moderating today's webinar. As part of NPE's educational programs, this webinar has the aim of informing members and other interested people about the highlights and important news in myeloma that were presented at ASH. The talk will be given by two renowned myeloma specialists. One of them you have already heard a second ago, Dr. Sonja Zweegman, and the other one, Dr. Niels van der Donk, from the BU University Medical Center in the Department of Hematology in Amsterdam. On behalf of NPE, I would like to thank both for their collaboration and for offering our members and all other interested people who have joined the webinar today the most up-to-date information on myeloma. This webinar, as many of you know, will be recorded and will soon be posted on the NPE website. I will remind you of the address afterwards, but all people that have registered to the webinar will receive that link once it is on the website via email. The seminar dynamics are as follows. We're starting a bit late, but we'll try to keep time, so we'll run for 1.5 hours. The presentation will last for about 1 hour, both the presenters, and then I will open a half-an-hour session for participants to ask any questions they have. Now, the options for this are, you can either make your question verbally, for those who have a microphone or the ones that have joined the webinar via phone. You just click on the icon with the raised hand, and I will give you the floor when it's your turn. Now, the other way of asking a question is in writing, and you can do that through the chat and the question window, and I will receive those questions in writing, and I will read them to our speakers. I have also received a couple of questions through via email, and I will ask that as well. So feel free, if you don't get, you don't manage to work out how the chat room works, just send me an email to plata@npeurope.org. So now, without any further delay, I will give Dr. Zweegman the floor.
Good afternoon. Can you all hear me? This is Sonja Zweegman from the Netherlands, and next to me is Niels van der Donk. We're only having one headset, so what I will do is I will first comment on the elderly trials that have been presented at ASH, and then I'll give over to Niels, who will comment on the more novel agents and the results that have been presented at ASH. Well, as we all know, it's here from Amsterdam, and we would like to have some ice for ice skating here, but still it's quite warm here. So the topics are the phase 3 trials in the elderly, which I will comment on, and then Niels will present the data on phase 2 and 3 studies with novel agents, and he will comment on the antibody-based therapy. Unfortunately, in the last years with the novel agents, with thalidomide introduced in the 90s and proteasome in the beginning of 2000s, the prognosis improved over the last years, and we're now coming in an era in which we have to choose between several agents in order to see what will result in the best outcome. So about the phase 3 trials in the elderly, we know that the novel agents do improve the outcome compared to melphalan and prednisone, and now at the ASH several trials have compared regimens, all implementing the novel agents in order to learn which novel agents will be the best for the elderly patients. And I will present data on IMiDs, and I will present the update of the first trial and also of our HOVON NMSG trial in the elderly, and then also I will comment later on the studies implementing bortezomib, because Marie-V Mateos has a presentation on that. So the first trial, here you see the design of the trial, compared lenalidomide with low-dose dex continuously with lenalidomide low-dose dex for 18 cycles and melphalan prednisone thalidomide for 12 cycles. The dosages that were used are now here in the slide. So 25 milligrams of lenalidomide, low-dose dex was 40 milligrams once a week, and melphalan was 0.25 milligrams per kg, and thalidomide in a rather high dosage of 200 milligrams. So actually it is here about continuous treatment versus treatment for 1.5 years. And what we learned in 2013, presented at the ASH, is that when you look at the progression-free survival, the progression-free survival was superior in the continuous RD arm, so RD until progression or toxicity, versus here in blue the RD 18 and the MPT here also for 1.5 years in MPT, so 1.5 years. And you can see here that at 3 years the progression-free survival here is 42%, and here 23% of patients were without progression using RD18 and MPT. So RD continuous is better as compared to RD18 and MPT. But what about overall survival? Here you see the overall survival, and what you can see here, that the overall survival in the RD arm is superior as compared to the RD18 arm or the MPT arm, and especially it was significantly different as compared to MPT. But now we know that in the very elderly patients, these regimens might be toxic. So therefore now there was an analysis on the patients over 75 years of age, and that was presented at last ASH by Cyril Lulin. What you can see here is that at least in the over 75 years of age, the melphalan dose was tapered. The prednisone dose was similar as compared to the patients with an age below 75 years, and the thalidomide dose was also less. So based on the age, there was a less intensive scheme used in the patients over 75. And what you can see here, when you look at the patients below 75 years of age, again you see that RD results in a improved progression-free survival compared to RD18 or MPT, so for 1.5 years of therapy. And this was also the case in the patients over 75. Progression-free survival was superior as compared to RD18 and MPT, although it was less pronounced, the difference. So that already points to the fact that in the elderly patients probably there's more toxicity, and more patients have to discontinue therapy because of this toxicity. When you look to the overall survival, again here the overall survival is superior in patients below 75 years of age. However, for the patients above 75 years of age, and I can't see it in the screen because I have something here in place, but again you can see that at 3 years the overall survival is superior in the RD arm as compared to the MPT arm. So also patients above 75 years of age benefit RD until progression. So what about the adverse events? Because then we were interested in whether the toxicity would be higher in patients over 75 years of age. And as you can see here, that in MPT arm, irrespective of age, there's more neutropenia as compared to the RD arms, and this also accounts for anemia and some less pronounced for thrombocytopenia. Infections are rather similar whether you're below 75 years of age or over 75 years of age, although the cardiac toxicity is higher in the MPT arm in the patients over 75. And also you can see that neuropathy is an issue when using thalidomide, and it is not an issue in the patients using lenalidomide. So when you adapt the dose in patients over 75 years of age, toxicity is rather similar as compared to below 75 years of age, and it also results in a progression-free survival advantage and an overall survival advantage in patients over 75 years of age, although a little bit less pronounced. So I think RD extended progression-free survival and also an overall survival benefit versus MPT, and that's regardless of age. That those adjustments are important in patients over 75, and also for the ones over 75, RD is a standard of care, and it will soon be registered and reimbursed for patients in order to be treated with lenalidomide and dexamethasone. So this is really an improvement in the treatment of elderly patients with multiple myeloma. What about our HOVON 87 NMSG 18 trial? We performed a trial in which we compared MPT followed by thalidomide maintenance, 9 cycles of melphalan prednisone thalidomide, again a high dose of thalidomide irrespective of age, so also the ones over 75 were treated with 200 milligrams, and then followed by maintenance with a lower dose of 100 milligrams versus MPRR, 9 cycles of melphalan prednisone lenalidomide, and then with a dose of 10 milligrams of lenalidomide followed by lenalidomide maintenance, and we compared these in patients above 65 years of age, and I think it's important to say that 35% of patients were over 75, so we had rather a large proportion of patients who were over 75 years of age. We hoped that MPRR would result in an improved progression-free survival as compared to MPTT. However, this appeared not to be the case. There was no difference in progression-free survival between the two arms, as you can see here. And progression-free survival was 20 months versus 22 months, and as I will show in a minute, for the first trial it was for lenalidomide dexamethasone 25 months, and also for the VISTA trial with MPV it was 24 months. So progression-free survival is between 20 and 25 months for the elderly patients with multiple myeloma, but no difference between the two arms. Also for overall survival there appeared not to be a significant effect. However, there were only 34% of events, so we might have to wait longer in order to see whether there will be an overall survival advantage for patients being treated with lenalidomide as compared to thalidomide, and the follow-up might be too short for that. What about the toxicity? And again, this was similar as compared to the first trial, in which you saw that neuropathy was a problem in the patients being treated with MPT, and it was around 10%. In our trial it was higher. When you see the grade 3 and 4 neuropathy, it was even 16%, whereas there was hardly any grade 3 or 4 neuropathy in the lenalidomide arm. So again, thalidomide induces neuropathy and a high grade of toxicity in patients over 65. And also it appeared that the feasibility of thalidomide maintenance was limited in patients maybe even irrespective of age, because you can see here that the median duration of maintenance was 5 months only for MPTT versus 16 months for MPERR. So the lenalidomide maintenance, we could continue lenalidomide maintenance for 16 months versus 5 months of thalidomide. So this is Niels, you can hear at the background. And that was mainly because of toxicity. You see that the toxicity is rather high in the thalidomide arm, and it was limited in the lenalidomide arm. So what you can conclude is that the MPR followed by lenalidomide maintenance is equivalent to MPT followed by thalidomide maintenance for progression-free survival, and they didn't show, but also for response rate. There is no significant difference in overall survival, but it might be that they will follow because there's only a limited follow-up. And again, thalidomide is less tolerated in the elderly and not preferred for maintenance strategies. And also in the first trial, the toxicity of thalidomide was higher. And also it was shown that in the patients over 75 years of age, continuous treatment with lenalidomide is a viable option. So similar to the RD trial in the first trial, the RD arm, over 75, it is possible to continue lenalidomide, because when I go back here, the discontinuation rate due to toxicity was similar in patients over 75 as compared to below 75. The difference was only minor. So lenalidomide for continuous treatment is a valuable option in patients with over 75 years of age. And also there was an update on the PATIMA trial, and in the PATIMA trial there was a kind of total therapy in the elderly patients. Here you see the study design. There was a sequential scheme, MPV 9 cycles followed by lenalidomide, dexamethasone 9 cycles, or it was alternated MPV, RD, MPV, RD, and also for 18 cycles. And the hypothesis was that this scheme, the alternating scheme, would be better as compared to the sequential scheme, because there would be less clones of plasma cells that would become resistant through therapy. However, the update was shown at ASH, and what you can see here is that there was no difference in progression-free survival and no difference in overall survival. What I think is important to state, that the progression-free survival, I just showed you all the progression-free survival dates between 20 and 25 months. Here you can see that progression-free survival improved to even more than 30 months. So that's a real improvement. And also when you have a look at the overall survival, you can see that overall survival at 3 years is 73%. So that means that at 3 years, 3/4 of the patients are still alive. And that might be higher as compared to the VISTA and the first trial, but it always is important to compare this in one study. So this is a non-head-to-head comparison. It's comparing one study with another study, and there might be different patient populations, but at least I think it's very good that we now can even reach progression-free survivals of more than 30 months and such a good overall survival. So what about the elderly patients? Again, also the patients above 75 years of age have a very good progression-free survival, 27 months. It is less as compared to the younger patients, but still it is a very good progression-free survival for patients above 75 years of age, and that also accounts for the overall survival. So when you compare all these new studies, you might say that for the VISTA trial, the total therapy approach is very good for the patients between 65 and 75, and toxicity has been acceptable, but the older ones could benefit for further optimization. So we should really look for a way to decrease the toxicity in order to improve also more the progression-free survival and overall survival in the patients over 75 years of age. But when you have a look at all these trials, I think what you can see from these trials is that when you have a look at the IMiD, so thalidomide and lenalidomide, and the proteasome inhibition, the bortezomib in the elderly patients with multiple myeloma, that it might be that a longer duration of therapy improves overall survival, and all the studies show that it's feasible to extend the duration of therapy. I think it's very important that we should not only look at progression-free survival, but also overall survival, and especially also quality of life, because we know when you treat continuously your disease will be repressed for a longer period of time because progression-free survival is better. But you all know that taking medicines will have side effects, so also your quality of life must be better, and preferably your overall survival is better, because otherwise it would also be suitable to give therapy for a limited period of time, follow it very rigorously and see whether there's an increase in M protein levels, and then start therapy when overall survival is similar. Well, when you look to RD, also overall survival is better than MPT, so that would favor continuous therapy, and we have to wait whether RD18 will also improve the overall survival, because then we can give therapy for a limited period of time. And now I think it's very important to discuss with your patient what is the burden of treatment versus what is the burden of the disease. When the burden of the disease is high, it might be good to aim for a long progression-free survival and continue therapy. When the burden of the disease is low, there's hardly any bone disease, then the burden of the therapy might be higher, and then you might consider just give therapy for a limited period of time. When you look to the total therapy in the elderly, so combining MPV and RD for 18 cycles, it might be better than single MPV or lenalidomide dexamethasone. But I think it's important to say that this has not been compared in one patient population, in one study, so we don't know yet, but I think there is the trend for longer duration of therapy, but again, you should weigh that against the burden of therapy. When it comes to thalidomide in the elderly, I think these studies have shown that although, by example, in the HOVON study, progression-free survival and overall survival is similar, the toxicity was much higher. And also in the first trial, progression-free survival and overall survival were less. So I think thalidomide in first line will be less used, and whenever it is possible, it won't be possible in all countries probably, but whenever it's possible, I think you should favor lenalidomide or proteasomib as a first-line therapy in the elderly patients with multiple myeloma. Well, again, there's also benefit in the patients over 75, but it's less pronounced, so we have a way to go, and we really have to optimize the therapy in order to decrease the toxicity and thereby improving the outcome. And I think, and I discussed that last year during the webinar, that geriatric assessments will be become more and more important in order to say whether a patient is frail or unfit, because then we would lower the dose and thereby enabling a longer duration of therapy, whereas in the very fit patients you might even have a look to more a longer duration of therapy. So there is a way to go in the treatment of elderly patients, and we are now implementing in HOVON but also in EMAN trials and trials over the world to implement the geriatric assessments, and hopefully at next ASH we will hear more about that, and that will learn how to give therapy in the elderly patients with multiple myeloma. And well, now I would like to hand over to my colleague Niels, who will discuss the novel agents with you, like ixazomib and Carfilzomib as proteasome inhibitors, and also the monoclonal antibodies. And I think, Ananda, it will be best to leave the questions for after the talks, or would you like to have the questions answered now on the elderly separately?
I think we should have the questions session at the end, if you don't mind, if that's okay with you.
Okay. So then I will hand over to Niels.
Wonderful.
Oké, ja. Zet het ding strak. Good afternoon, everyone. Can you hear me?
Yes, we can hear you. Good afternoon. This is Ananda. Go ahead.
Okay, so this is Niels. Yeah, so this is Niels van der Donk from VU Medical Center. And as Sonja already mentioned, I will continue with some data about novel drugs. And one of the novel drugs is Carfilzomib citrate, which is an orally available proteasome inhibitor. So it's a pill, and it's actually it looks a lot like Velcade or proteasome, but the disadvantage of Velcade is that you have to give it subcutaneously or intravenously every week, but Carfilzomib can be given as a pill just once weekly, so very convenient and very friendly for the patient. Carfilzomib can be combined with lenalidomide and dexamethasone, and that's a combination of a proteasome inhibitor pill, dexamethasone pill, and lenalidomide is Revlimid, is also a pill, so it's a very effective combination of 3 pills. And at ASH there was a presentation of Tumor, who gave this triple regimen in newly diagnosed patients with multiple myeloma, actually elderly patients, he treated 21 patients with this combination, and I have to say that after 12 cycles of this treatment, patients received maintenance with Carfilzomib. So that means that they received Carfilzomib only and not the other drugs, once weekly. So here you can see that most patients, 92% of the patients, that could take the drug, so that only a few patients had to stop the drug during induction or during maintenance, which is indicating that Carfilzomib, but also lenalidomide and dexamethasone, are well tolerated. Here you can see a slide in which you can see that the response to the 12 cycles of induction treatment is very good responses, but more importantly is that when you continue with Carfilzomib maintenance therapy, that the response even improves further. So a very good and effective treatment regimen, which was also well tolerated. So this combination is very promising for the future. It's fully oral, and variations of this will also be evaluated in the European countries. For example, in the Netherlands and in the Nordic countries, we will combine Carfilzomib with thalidomide and dexamethasone, which is a study led by Sonja Zweegman. Then I would like to discuss the novel agents which are used for relapsed multiple myeloma, so when the myeloma comes back. And one of the drugs that can be used in the relapse setting is pomalidomide. Pomalidomide is a drug that looks a little bit like lenalidomide, but as I will show you, it's also active in patients that do not respond to lenalidomide anymore. So in the Stratus study, patients received pomalidomide and low-dose dex, and all these patients had received lenalidomide previously, and all of them had also received bortezomib previously. And most of them did not respond anymore to these drugs. So here you can see that in the Stratus study, the patients received pomalidomide 3 weeks every 4 weeks, and once weekly dexamethasone. And the patients received this treatment regimen until progression. Here you can see that the median progression-free survival was 4 months. So of all the patients, it takes 4 months median until they progress. However, when you obtain a response, and 40% of the patients get a response when they receive pomalidomide and dexamethasone, when they get a response, the duration of the response is 8 months, which is quite good in this population of lenalidomide and bortezomib refractory patients. The overall survival was 12 months. And then there is a lot of studies going on of how to make pomalidomide, dexamethasone more effective. And one of the things that you can do to make pomalidomide and dexamethasone more effective is to add a third drug. And the third drug that can be added in this regimen is cyclophosphamide. So Rachid Bas from the Moffitt Cancer Center in Florida evaluated two regimens, pomalidomide and dexamethasone, as I discussed in the previous slides, and he also tested pomalidomide, dexamethasone plus cyclophosphamide. And he compared response in PomDex versus PomCyclodex. And here you can see the response in these two groups, and you can see that when you add cyclophosphamide, that the partial response increases from 40% to 64%, and also minor response or better increases from 60 to 80%. So this suggests that PomCyclodex is better than PomDex in terms of response. However, for the patients, of course, it's very important that also the progression-free survival improves, and that was indeed the case. Patients that had pomalidomide dexamethasone with cyclophosphamide, the red curve, had a better progression-free survival and overall survival, as shown here, than the patients that received pomalidomide dexamethasone only. So the addition of cyclophosphamide makes the efficacy of pomalidomide better. Another interesting combination that can be used in the relapse setting is Carfilzomib plus lenalidomide and dexamethasone. And in the Aspire study, Dr. Stewart from the Mayo Clinics in Arizona compared in patients with relapsed multiple myeloma Carfilzomib Lendex versus Lendex. And you can see that they received 1 to 3 prior regimens. And this combination was given for 18 cycles, and every cycle was 4 weeks. And after that, the Carfilzomib was stopped, and Revlimid and dexamethasone were continued. So here you can see how the regimen looks like. Carfilzomib is administered every 4 weeks at days 1, 2, 8, 9, 15, 16, intravenously, so you get an infusion. Lenalidomide are pills, and dexamethasone are also pills. The interesting thing about Carfilzomib is that it is also, like Velcade, an inhibitor of the proteasome, the machinery of the cell to degrade rubbish and old proteins. But Carfilzomib is more effective in that respect because it can inhibit much stronger the degradation machinery of the cell. Another advantage of Carfilzomib is that it has a very low frequency of polyneuropathy, while bortezomib, Velcade, induces a significant rate of polyneuropathy in patients. So in this regimen, CRD regimen, the CRD regimen has already been tested in relapsed patients, but also in newly diagnosed patients, and it has been demonstrated that this combination is very, very effective. But in the Aspire study, for the first time in a randomized fashion, CRD is compared with RD. And you can see that the response rate was much higher in the CRD group than in the RD group. So the yellow bars are the KRD and the orange bars are the RD patients. So you can see that the response rate is much better. And when you have a better response, this often translates into a better progression-free survival, and indeed the proportion of patients surviving without progression was significantly longer than patients with RD. And the difference was 8 months. So the progression-free survival was 8 months longer in the KRD arm compared to the RD arm. And also the overall survival was better in the KRD arm than in the RD arm. So we think that KRD is a very effective triple regimen that can be used in the patients that have a relapse disease, have a relapse of their multiple myeloma. Here you can see that the side effects of the KRD combination are quite mild. However, you can see that the number of cardiac events is a little bit higher when you add Carfilzomib compared to RD alone. Oops. Sorry for the interruption. So in general, we can conclude that KRD is better than RD, better response rate, longer progression-free survival, longer overall survival, and it's quite well tolerated. So we think that KRD will be an important step forward in the treatment of multiple myeloma. Then the final part of my talk about new treatment regimens is about antibodies. And since very recently, since maybe 1 or 2 years, we have the opportunity to also treat patients with multiple myeloma with antibodies. And antibodies are small proteins depicted here in green, and these small proteins can bind to a tumor protein, for example CD38 in the case of daratumumab. And after binding of the antibody to CD38, they can activate the host's, the patient's own immune system, the effector cells, but also the complement system. And when these antibodies activate the immune system of the patient, that will lead to killing of the tumor cell by the effector cells or by the complement system after the formation of pores. So these antibodies activate a patient's own immune system and have relatively little side effects. Well, at this moment we have several anti-CD38 antibodies available, and we also have an anti-CS1 antibody available. And the anti-CD38 antibodies are called daratumumab, SAR, MorphoSys, and the anti-CS1 antibody is called elotuzumab. Sometimes these antibodies are fully human, but some of them are humanized, so they still contain some little parts that are of mouse homology. But in the past, these antibodies were fully mouse, and you can imagine that when an antibody is fully mouse, that you have a bigger chance of forming an allergic reaction. But in the case of humanized or human antibodies, this is much less observed and virtually not observed in case of human antibodies. So this is important in the clinical application of antibodies. What we have shown in our VU ziekenhuis, in VU Hospital in Amsterdam, is that when we treat mouse with multiple myeloma with daratumumab, that you have a significant reduction in tumor load. So in the mouse, daratumumab as a single agent is very effective. However, you have to demonstrate efficacy of daratumumab in human beings. So that's why there was a phase 1/2 study in which patients were treated with daratumumab monotherapy, and these patients responded very well to daratumumab. 40% of the patients had a very good response to daratumumab monotherapy. And based on these findings, several combinations were further explored. And one of the combinations that was further explored is the combination of daratumumab with lenalidomide and dexamethasone. And the interesting thing about lenalidomide is that lenalidomide activates the human immune system, so it's a very rational combination to combine daratumumab with lenalidomide, because lenalidomide will activate the immune system, which is so important in the mechanism of action of DARA. So in this phase 2 study, phase 1/2 study, 43 patients were treated with DARA, lenalidomide and dexamethasone. And in this immunotherapy schedule, there was a dose escalation, so patients received increasing dose of daratumumab. And you can see that the M protein was significantly reduced in almost all patients. And when you plot that in a bar graph, you can see that the response rate was very, very good. And what you can see here is that the response rate improves every cycle. So the VGPR rate, very good partial response rate, increases from 40% to 50% to 53% when you treat the patient with additional cycles of lenalidomide, dexamethasone plus daratumumab. Well, daratumumab is not the only anti-CD38 antibody. We also have SAR, and also SAR is an antibody which targets CD38, and also this antibody has been tested in a phase 1/2 study. In contrast to the previous study, many patients in this study were also exposed to lenalidomide and not responding to lenalidomide anymore. But also in this study, the combination of SAR, Lendex was very effective with a very good response rate of 60%. And this response rate was observed in lenalidomide refractory patients, bortezomib refractory patients, patients with high-risk cytogenetic disease. So a very promising combination again. And here you can see the progression-free survival, which was 6 months in a heavily pretreated group of patients. And the progression-free survival was better in patients that were less pretreated than when patients were more pretreated. Well, here is a sort of a summary in which you can see that daratumumab plus Lendex is very effective with an overall response rate of 90%, but also SAR Lendex is very effective with a response rate of 60%, but many patients here received already lenalidomide. And also elotuzumab plus Lendex is very effective with a good response rate and also a very good progression-free survival. So I think, and that's my conclusion, that at this time we have multiple drugs available for the treatment of multiple myeloma. We have thalidomide, lenalidomide, and pomalidomide. I discussed pomalidomide in the STRATUS study, and all these drugs are called IMiDs, immunomodulatory drugs. But we also have several proteasome inhibitors, not only bortezomib, but also the irreversible inhibitor Carfilzomib, which is effective in bortezomib refractory disease. And now we have also the opportunity to give our patients in the setting of a clinical trial orally available proteasome inhibitors, such as ixazomib, which I showed you some data of. And we also have oprozomib, which is also an orally available proteasome inhibitor. We also have all drugs, such as melphalan, cyclophosphamide, doxorubicin, which can still be very valuable in the setting of refractory disease. And we have to combine steroids with all these drugs, dexamethasone or prednisone. But what I want to add to these 4 classes of drugs is the class of monoclonal antibodies. So anti-CD38, which I discussed, but also anti-CS1, elotuzumab, which I discussed. And it will become increasingly difficult to choose the best combination of drugs for each patient in the newly diagnosed phase, but also in the phase of relapse refractory disease. And when you pick a combination of drugs, you have to take into account patient features, myeloma features, and also which therapies the patient already had received. And based on these features, you can give your patient the best combination of drugs of which he will be optimally benefiting. So I think this was my last slide in which I summarized the state-of-the-art 2015, what we have available at this moment, at least in the clinical trial setting. So that was the presentation of Sonja about a newly diagnosed setting, and my presentation about drugs that hopefully become available in the upcoming months, up till years.
Thank you very much, Dr. van der Donk, and well, thank you both actually for such comprehensive presentations you've given us. I think I'll be downloading it again and watching it again once it's online. I'm pretty sure that there are many questions from the audience, and so I would now like to invite all of you to raise your comments and ask your questions. I'm just going to shortly remind you that the possibility of posing questions you can do verbally for those who have a microphone or are logged in via phone by just clicking the icon of the raised hand, and I will then give you the floor. Or in writing through the chat or by sending me an email. You have a question window in your webinar window that is opened on your screen. Just click on that and I'll give you the floor. First of all, I think I'll be reading out. I got a couple of questions from the audience. The first one I'd like to read is from Hans Scheurer. He was asking whether Carfilzomib will replace bortezomib in the future because it's less toxic and gives less neuropathy. I'm not sure whether you
Well, it's a very good question. Bortezomib is a very active drug, and we have been using it for a very long time. So we know the side effects and we know how to handle it. Carfilzomib seems to be is effective in bortezomib refractory disease, and in combination with lenalidomide and dexamethasone is probably the most effective regimen at this time. And it's increasingly being used in newly diagnosed patients in the United States, but in Europe we cannot give it at this time in myeloma patients, but hopefully in the future we can give it in the setting of relapse disease. Carfilzomib gives less neuropathy, and that's very important because many of our patients have neuropathy as side effect developed during treatment with bortezomib or thalidomide. So carfilzomib will be very effective for those patients and probably also very well tolerated. The thing is that carfilzomib we do not have so much experience with at this moment, and it seems that it also can induce a little bit more cardiac side effects. So whether it will fully replace bortezomib, I think the next few years, no, because we know how to handle bortezomib, it's effective, and we have not the availability of carfilzomib now at this time point for the newly diagnosed patient. But maybe when we have more information, when we have more studies available, maybe carfilzomib will also transfer to the first line setting. And in Europe, we will soon start actually a study with carfilzomib, lenalidomide and dexamethasone in newly diagnosed patients with plasma cell leukemia. And plasma cell leukemia is the most aggressive form of myeloma, and that's why we will treat these patients with the best combination in this clinical trial. But outside of the clinical trial in Europe, it will not be available for the next few years for newly diagnosed patients. But we expect that CRD will become available next year in the setting of relapse disease. So that's my answer.
Oh, thanks for that. There was one other question that came in regarding diarrhea while using lenalidomide and dexamethasone, and what your suggestions would be when the desire of continuing with lenalidomide is there. And the diarrhea becomes worse, if there's any suggestion.
When patients get diarrhea because of lenalidomide, you have to, of course, see what's the dose of lenalidomide, can you reduce, in what phase is the patient. Sometimes it helps when you add loperamide, which stops diarrhea. And very recently a paper has been published by the English myeloma study group, which demonstrated that in some patients the diarrhea induced by lenalidomide is caused by an increase in bile acid secretion, and they showed that it's very effective, or can be very effective, to give these patients a bile salt binding drug. So there are some supportive care tricks that you can try to make this diarrhea more tolerable or even go away. So loperamide can be tried, which is a very safe drug, which you can also buy in the drugstore next door. But you can also discuss with your doctor the paper of the English myeloma group. First author was Charlotte Paulin, in which she described the efficacy of cholestyramine, a bile salt binding drug. So several tricks which can be used to make your life, the quality of life better, because it's very important, especially in relapse disease, to continue your treatment.
Thanks for that. So there is another question, whether this means what you have just presented or talked about, whether it means that stem cell transplant treatment will be phased out and replaced by the novel drugs.
That's a very good question again. In this slide, I don't know whether you can still see it. I still have the alkylators put. So melphalan is given as conditioning before the autologous stem cell transplant. And there are indeed many discussions going on whether autologous stem cell transplantation is still important. Now we have very effective IMiDs, now we have very effective proteasome inhibitors, now we have monoclonal antibodies, and of course the steroids. And two of these studies will soon present their first data. So it's the European study EMN02, HOVEL 95, in which also many European, Dutch, Italian, Nordic patients participated. In total 1,500, and in this study and also in a French-American study, the FCI study, the question was, do we still need autologous stem cell transplant or not? But we do not have the data of this study at this moment. A study from the Italian group also tested autologous stem cell transplantation or no transplantation, but in this Italian study the patients did not receive a combination of all these drugs, but only lenalidomide and dexamethasone and melphalan. And in this study, in which there was only lenalidomide, autologous stem cell transplantation patients still had a survival benefit. So at this time, I think we still can say that patients benefit from autologous stem cell transplantation when they are young and fit, of course, otherwise you cannot give it. But there are several studies that are questioning this and asking themselves whether we can reserve the transplant for first relapse. And there are several hypotheses and opinions about this. I think transplant still has a very important place because it can also lead to a very deep response, and a very deep response, especially when you give a combination of proteasome inhibitors and IMiDs, translates in a better survival. And you can also consider to stop treatment after the transplant when you have achieved a very good deep response, and when you are off treatment and you have several years without treatment, that also contributes to a good quality of life.
Thank you. We have one more question from Mira Armour. I'm going to switch on the microphone. Mira, can you hear us?
Yes, hi. Good
Hello.
Afternoon.
Hi.
Hi. It's very complex, all the things you've told us. I have two questions regarding my members in Croatia. One is to do with someone who had various treatments, so he's heavily treated but never responded in a way that his plasma has reduced. Mm-hmm. What is your feeling? He's being offered Revlimid now with dexamethasone or without it, and is there a possibility of transplantation still in his case? He's at 55. I know it doesn't have to be specific to him, but just your feeling in general on heavily treated people with Velcade and this and that.
Well, of course, I have not seen his charts, and it's very difficult to comment on this very on this case. But I think when the patient that did not receive lenalidomide yet, the combination of lenalidomide and dexamethasone is a very good option. And when he achieves a good response, and you are still in the opportunity to harvest stem cells, because maybe he had received stuff that makes it difficult to harvest stem cells, you could consider that. But I think it's good that he discusses all these options with his own physician.
Yes, he will. The thing,
Okay.
I mean, he's confused with that he has read that lenalidomide is given in combination with dexamethasone.
Lenalidomide with dexamethasone is a very good combination, which we often give in the relapse setting. So that's a very good, effective, well-tolerated combination.
And would that be given, I mean, dexamethasone, is it given just at the beginning of the cycle, or it's every 7 days? Or does it matter?
Mostly we give dexamethasone once weekly, depending on the age, 40 or 20 milligrams.
Mm-hmm. Not just at the beginning of the 21 days.
Maybe he has a lot of side effects, and then you can consider to only give it once a month. Maybe there was a good reason for that, but mostly we give it once weekly.
Okay. Thank you very much. That was great. And I've got, so you think still he can have possible chance of a transplant if he has a good response, unless his stem cells have been damaged, yeah?
Exactly. When he had received melphalan, prednisone courses, cycles, it will be very difficult to harvest stem cells because melphalan is stem cell toxic. It's not good for the stem cells. It will be difficult to harvest them. But maybe he had not received that yet, and there is still an opportunity to do that. But he should discuss it.
He will. Thank you very much. One more question. Have you any experience of or hearing that myeloma patient who is in remission was offered and had kidney transplant?
A kidney transplant in a multiple myeloma patient.
Mm-hmm.
Oof. Maybe the patient had suffered from light chain deposition disease or amyloid disease, so the damage is because of the myeloma clone. I know in the world there had been some kidney and also in combination with a bone marrow transplant cases.
Mm-hmm.
Because you are afraid that disease comes back in the transplant kidney. So you have to really get rid of the myeloma clone, and you have to get rid of the, so that the protein cannot deposit anymore in the kidney. But I know in the Mayo clinics and in Boston, and I think also one case maybe in the Netherlands, they have combined allo transplant, so bone marrow transplant, with kidney transplant.
Allo?
Allo, because, yeah.
Not the allo transplant.
I think that was allo, but I should look back in the literature about that.
Okay, well, thank you very much.
Mm-hmm.
Thanks,
Well,
Mira.
you're welcome.
Thanks, Mira, for your questions. I have one more question from Hans. He wrote, Antonio Palumbo said that it was recommended to, although in complete remission, to stay in continuous treatment because there is always a rest disease. And he would like to know what your opinion on this is. And should we never stop using these drugs for a period?
So there's a big debate going on about maintenance. Many studies have shown a progression-free survival benefit, but only one of the 4 studies has now shown an overall survival benefit. One of the studies that showed last year a survival benefit, the Palumbo study, did not show in the update a survival benefit. So there are different ways, and still a lot of discussion about maintenance therapy after transplant or after therapy. and we need still a lot of studies to be done, but I think that there is a subgroup of patients that benefits from continuous therapy, and actually we often do continuous therapy in the relapse setting. We give lenalidomide, dexamethasone in the relapse setting until progression. We often try to continue bortezomib until progression. And also, for example, the combination of lenalidomide and cyclophosphamide is given until progression. So in the first line there is a lot of discussion because it does not translate at this time into an overall survival benefit, but it prolongs progression-free survival, and that may lead to postponing of nasty myeloma events, and thereby improve quality of life. However, there are also side effects of maintenance, and when you stop treatment after autologous stem cell transplantation or after 9 cycles of therapy, it's also very good for the patient to be off treatment. So I think more studies have to be done to get a better insight into the benefits and disadvantages of maintenance therapy. So at this time point there are a lot of questions still remaining, and that's why in the guidelines of the Hopeful Myeloma Working Group we still do not recommend lenalidomide maintenance. I'm looking at the main author, the first author of the guideline, but she agrees with my comment, Sonja Zweegman.
Thanks. So I just got another question in from Amina Ali. She's asking, what is the status of methods for detecting SCR and MRD?
So stringent CR is done by looking in the blood to the M protein, by looking in the urine to the M protein. You do a bone marrow biopsy. Oh wait, for stringent CR you also look at the light chains in the serum, and you do a bone marrow biopsy. And for stringent CR you look in the biopsy whether you can still detect clonal plasma cells by using immunohistochemistry. But when you look at MRD, you use flow technique or a molecular technique which is much more sensitive, so that you can detect one tumor cell in 100,000 bone marrow cells. So the sensitivity of MRD is much better than stringent CR measurements. So that's why an MRD, when you obtain MRD negativity, that results in a very, very good remission duration and survival.
So I see that there's no question coming in from the attendees, so I'm gonna just go ahead with mine, which probably is a very simple one. But what do you think? How long does it actually take from an ASH presentation into really changing clinical practice? What does it usually? How much time does it take? I always wonder.
Well, some things are going very rapid, of course. So the pomalidomide is becoming available, and was an oral this ASH and last ASH. Antibodies will be moving forward very, very rapidly. So daratumumab will become available at the end of this year, probably in a compassionate use program for patients. So it's also being translated from studies to and become available for many patients in a very rapid period of time. So I think, in contrast to many years ago, the translation from ASH to basic practice is much faster at this time point.
So probably the only question or the only
course,
barrier is the price
patients,
at the moment.
The price, of course, has to be is an important thing, especially when you want to combine three expensive drugs. But patients, of course, have always the opportunity to participate in a clinical trial, and then the product is free of charge, and the patient can benefit from an early access to a novel drug. So many patients in the Netherlands had early access to daratumumab in the setting of a clinical trial, for which there were no other options anymore. And they still, and some patients really benefited for many, many months and could after that continue with another drug that became available. So that's the advantage sometimes of participating in a clinical trial, that you have early access before the drug is available at the market to be described, to be prescribed by by all doctors.
And do you think, I mean, there's always a huge debate going on chronification of myeloma, and you never really know if you're allowed to say the word or not. And what about talking about cure? Do you think a cure is on the horizon, or how far away is it?
When you look at the curves, the long-term survival curves, there seems to be a plateau, and maybe 10 to 15% of the patients that have been transplanted are cured. However, we need additional follow-up to be sure that they are not relapsing after 20 years or after 15 years. But there seems to be a small proportion of patients with such a long-term survival that they are cured. And hopefully, with the new drugs that are becoming available, this fraction of patients that are cured increases even more. And also the total therapy programs of Dr. Balogi have shown a plateau with some long-term surviving myeloma patients. So I think we need additional follow-up to see how the long-term survival will improve. But I started with the slide in which you can see the 5-year survival of myeloma patients, and what you can see is that the 5-year survival is really dramatically improving over the last few years with the advent of the novel drugs, with the introduction of the novel drugs. So hopefully this will also translate into an increasing percentage of patients that will not get their myeloma back. But we need, of course, longer follow-up, because when you start patients in 2010, you have to wait until 2030 before you know how many patients are really cured.
Thanks. We have one more question from Hans coming in. He's asking, why are the new treatments mostly combined with dexamethasone or prednisone? Especially DEXA is very interruptive in the patient's character and well-being. Is it worth it? And then he adds, a lot of patients hate dexamethasone effects in their lives.
It's a very good question. Dexamethasone is often used as a backbone drug for all types of myeloma treatments, because there seems to be some synergy between bortezomib and dexamethasone, lenalidomide and dexamethasone, carfilzomib and dexamethasone. So this combination often improves response. And we also give it to patients that receive antibody treatments, because then we need it as infusion reaction prophylaxis, so to prevent infusion reactions. So because the antibody, especially the first gift, can lead to complaints of coughing or a little bit of trembling, and you can prevent that with prednisone or dexamethasone. So also in the antibody therapies, these treatments are combined. However, of course, when patients have side effects of dexamethasone, you have to dose reduce. When patients have severe side effects, you can also consider a low dose of prednisone, but then continuously. So, for example, in the lenalidomide cyclophosphamide prednisone regimen, we do not give dexamethasone once weekly, but we give prednisone every day at a low dose of 20 milligrams, which is often much more friendly for the patient, giving less side effects, less mood disturbances, less depression, less talking, and so on. So when you have these complaints with dexamethasone, discuss it with your doctor whether you can get rid of your prednisone or dexamethasone, dose reduce, or shift or other tricks.
Thank you. We have one question via microphone from Anna Pereira. Anna, can you hear us? Anna?
No questions anymore? Okay.
Anna?
Okay.
Well, hang on. I think we have one more last question from Mira. Maybe Anna appears. Mira, can you hear us? Just one quick one.
Yes, I can. A quick one, just to see whether I understood properly. Did you say that in patients who are on combination with dexamethasone, if they have bad side effects like restlessness and, I don't know, diarrhea and God knows, they can be moved to prednisone or to discuss it with doctors?
You have to look at the tumor state. For example, when you have lenalidomide dexamethasone, you can give 8 or 9 cycles, and when you have a good tumor reduction and you have a very good response, you can also consider to stop dexamethasone and continue with lenalidomide maintenance when the patient has side effects. And sometimes we give in patients with diabetes, we consider prednisone because we give it continuously, so the blood sugar levels do not shift so much in contrast to when you give dexamethasone 40 milligrams once weekly. So there are all sorts of tricks which you can discuss with your doctor, whether you can shift from dexamethasone to prednisone continuously, or whether you can lower the dose, or whether you can go on with lenalidomide alone as maintenance instead of lenalidomide dexamethasone treatment.
Okay. All right then.
But discuss it with your doctor because it depends on your tumor load, it depends on side effects, it depends on other tricks that you can do. What's the best option for the patient?
Right, okay. Lovely. Thank you. Short
Okay.
and sweet. Thank you very much.
You're welcome. Also for Dr. Zweegman, she waves to you.
Bye.
Okay, bye-bye.
Okay, I think Anna has appeared, so we will take the last question now from Anna Pereira. Can you hear us now? Anna? Well, she doesn't seem to, although she said she was. She was asking in writing whether any of these drugs seem to be better for high-risk patients with bad karyotype.
Is that a question or?
Yes, that is Anna Pereira's question, and
there are still a lot of studies being done now, but it seems that the proteasome inhibitors are very effective in high-risk disease, but also the IMiDs have some advantages. But for the more novel agents such as daratumumab and elotuzumab and other drugs, we still have to get results of their efficacy in high-risk settings. So we do not know yet.
Okay. Well, thanks a lot. I know that you have answered all the questions. We're very grateful for that. And Dr. Zweegman, I would like to thank her as well. I know she can't hear me now. But please let her know on behalf of NP that we're very grateful for your time and for the wonderful presentation you both have done. So we've reached, I think, the end of our time. And as I said at the beginning, we will be posting the recording on the website, and you will all get a link to that recording. I thank you once more, and I'll hope to be in touch. Thanks a lot for your time.
Okay, you're welcome. Okay, bye-bye.
Bye.